Thank you very much. I'd like to take requests from the chairperson, Dr. Kamal Sam Lodi, to start the plenary session. So the plenary session for 2025, it's going to have name lecture awards, and it's going to have the prestigious Ramzan Ali Sayyid name lecture award as well. The Ramzan Ali Sayyid is sort of, his date of birth was from 1901 to 1988, and he was born in the suburbs of Lahore, and he did metric from Dave High School and FSC from Government College 1921 and MBBS from King Edward in 1926. His distinctions in medical studies, honors in anatomy, midwifery and hygiene, DOMS in London and DLO from London. At that time, they were the highest degrees from that area. He's the most laureated ophthalmologist of all times. And on returning to India, he was selected by PPSC as a clinical assistant to the professor of ophthalmology and posted at King Edward. After partition, he was the first Muslim professor of ophthalmology at King Edward Medical University, medical college at that time, in which he served till 1958. He then joined Fatma Jinnah Medical College as professor of ophthalmology and remained there till 1966.
These are actually based on research indicating if the eye is made hypermetropically defocused, the eye length increases to make it emmetropic. And if it is converted to myopically defocused, the growth of the eye stops and its elongation reduced, and eye do not become so long to call it myopic or progression. So actually the predominant cause is the axial elongation of the eye. Peripheral hyperopic retinal defocus stimulates it. It is mediated by neuromodulators like dopamine, melatonin, and acetylcholine. These signals alter the scleral extracellular matrix remodeling, leads to elongation of the posterior globe, and once the globe elongates, then you can imagine the degenerative macular degeneration and so many other complications. What factors are leading to the progression and initiation of the myopia and leading to such a high burden in the future? When we look at the factors, these have been divided into two major groups. The one which is related with genetics is non-modifiable factor, but environmental influences are dominant drivers of the global myopia epidemic and are recognized as modifiable risk factors. When we look at the genetic or and the parental factors, it's really very important. The transmission is through more than 400 loci which has been identified so far. If one parent is myopic, the risk of having in the next generation is 3 times. And the risk increases, becomes 6 times if both the parents are myopic. But when we look at this, is not easy to change the genetics, and it's only the marriage counseling for the next generation that you can alter few of the results. But look at the modifiable risk factors. I have noted here 8 factors, of which these 4 in the first table: reduced outdoor time, excess near work, reduced reading distance, and the excess screen exposure are the highest ones which are affecting to lead to myopia. These next table, academic load, sleep, and indoors, diet, physical activities also play a significant role. When we look at and the research reference to the reduced outdoor time, there is very strong evidence indicating that if the outdoor activities of the children is reduced to less than 1 hour and a half, 1 hour and a half to 2 hours, the myopia progresses very rapidly. And meta-analysis indicates if these children are given chance to stay outside more than 2 hours, 3 hours, then 30 to 50% reduction can take place in onset and likewise in progression. The research on the excess near work has also given strong evidence that more than 2 to 3 hours day continuous reading, digital use or close-up task, prolonged near focus increases the accommodative demand, and this leads to peripheral hyperopic defocus and ultimately to axial elongation. And this risk increases 2 to 3 times when 3 hours per day near work without break is done by these children. The same about evidence, although not very strong, but moderately strong evidence, the research provides to us that if the children have reading distance less than 30 centimeters during their work, close work, this amplifies the retinal dangerous defocus signals and becomes a consistent independent predictor of the progression. So the next factor is the excess screen exposure. Although moderate evidence is available for it, the 2 to 3 hours per day screen use leads to blue light exposure, reduced blink rate, sustained near accommodation, and is especially risky when combined with the low outdoor. These next coming 4 factors, although not very strong evidence available for these, but have been proven factors to cause increase in the myopia as the academic load, which has been noted in the East Asia cohorts, and it is of course a confounder for the reduced outdoor exposure as well. Sleep and circadian rhythm, if less than 8 hours, irregular bedtime dysfunction reduces the dopamine and melatonin balance, alters the eye growth signaling. Inadequate light indoors is also one of the factors, and so is the diet, physical activity. But when we look at the relative impact summary, you will note that the first 4 factors are responsible for about 90% of the cause of progression in modifiable factors. So keeping this in mind, we look for the current management strategies for myopia control. We will see the environmental behavior modifications, pharmacological interventions, optical interventions, surgical options. Behavioral modifications are quite evident that we have to increase the outdoor activity more than 2 hours, and the close work continuity has to be broken into small spans, 20-22 rules, in which every 20-minute near work, 20-second break, and to see at 2 meters away. And similarly, the distance, increase the reading distance to more than 30 to 40 centimeters. Reduce evening screening time, ensure the bright study environment to more than 1,000 lux preferred, encourage the sports and physical activity, and these behavioral modifications can retard the progression of the myopia. Mechanism of the outdoor protection, and likewise, when we looked at the pharmacological intervention, the atropine is one drug which has been under research in whole of the world, and it has been noted that the low dose atropine 0.01% to 0.05% is quite effective. Studies which helped us reach this conclusion are ATOM 1, 2 and LAMP studies, and the mechanism mentioned for the atropine to control the myopia progression is its effect through the muscarinic receptors of the retina and the sclera, which inhibits the remodeling of the scleral extracellular matrix and stops the signal for axial elongation. It's not related with accommodation. atom studies were done in Singapore, and they noted that atropine, if in full strength, is very, very effective, up to 70%, but it has so many complications. But in atom 2, they noted that low dose, 0.01%, is effective, although less than the full dose, but it's free of the complications. Hong Kongian people came forward and they found that in the LAMP studies that 0.05% is better in controlling than 0.01% and is having minimal complications. And their series, fifth LAMP study, helped us know about the concept of rebound, which actually occurs if we stop the drugs suddenly, especially the high dose, 0.05%, and that's why it's recommended that it should gradually be tapered between 6 to 12 months. Then we move on to optical interventions. It is a more established and accessible strategy, particularly in the children, not only corrects the refractive value, but also influences ocular. And also influences the ocular growth by modifying the peripheral defocus. Based on the evidence, the peripheral of these lenses defocuses the image, while the center of the lens gives the refraction and stimulates, and the peripheral myopic defocus inhibits the growth. On this rule, optical intervention has been done through the glasses, DEMS and HALT lens, night wear contact lens are orthokeratology, and the day wear contact lenses as my side. This is the picture showing the DEMS lens and the HALT lenses. And the orthokeratology wears these are the overnight wear of the specially designed rigid glass permeable lenses, which temporarily reshape the cornea surface to correct refractive errors and induce the peripheral myopic defocus during daytime, and thus decreasing the progression of the myopia as well. In contact lenses, similar variety is available in which the center of the lens works separately for refraction and the periphery gives the defocus. The new emerging interventions are low-level rigid light therapy, combination therapy, personalized treatment. The repeated low-level red light is a recent one, and the low-intensity red light at wavelength of 650 to 660 nanometers is administered in brief repeated sessions using specialized desktop or wearable light emitting devices, and mechanism of it is stimulation of the mitochondrial activity and increased ATP production in the retinal cells, potentially influence the choroidal blood flow and scleral remodeling. Is a valuable future intervention. Combination is under trial, and there are several combinations of which the atropine is always there. Surgical options are typically not fit for the children's, of which the posterior scleral reinforcement is the one in which placing a biocompatible graft such as donor sclera synthetic material on the posterior pole of the eye stabilize the scleral wall to slow the progression of the myopia, but this is only for those cases in which no other measure helps. So a systematic approach to select the patient and treat them with the different combinations is the demand of the day. So the last words from me that we must make some urgent national myopia campaign to form the policies, guidelines, and implement with the serious intention to school at family level. Thank you so much for kind listening.
Thank you very much, Professor Mia Shafiq. The next lecture is going to be the Professor Raja Mumtaz Lecture Award. He's remained is the pioneer, or you can say the father of Ophthalmology Society of Pakistan, and he was the most distinguished ophthalmologist, one of the most distinguished ophthalmologists with us. And he remained the president of the Ophthalmic Society of Pakistan, and he remained the patron-in-chief of the Society of Pakistan Lahore branch, and he was the founding general secretary in OSP in 1957. And the energy which he had to sort of promote ophthalmology, and he would attend all the international meetings at that time. And I think if you can see his attire, that was his trademark. He would go to USA, UK, or South Asia, and he will wear that his Pakistani achkan with him and his jinnah cap with him. So he was very proud to be a Pakistani, and he promoted ophthalmology wherever he went. And whatever he was into, promoting research in ophthalmology, promoting as much of education of trainees in ophthalmology, and building up and making a coherent ophthalmic society, laying down the foundations of the constitution along with all the members at that time. So he served and he did a great deal of good work for the Ophthalmic Society of Pakistan. And we have a very befitting speaker for him today. And it is Professor Andrew Bastoras. He's going to talk on how to change hearts and minds of vision, tipping the curve in Pakistan. He's a professor in global ophthalmology at the London School of Hygiene and Tropical Medicine, co-founder of and CEO of Peak Vision and co-founder of Vision Catalyst Fund. He has worked and undertaken research in over 20 countries, including 2 years living in Kenya, where he was a leading major eye disease study and development and testing of the earlier versions of Peak smartphone-based eye health system. Andrew has been listed as one of the world's 30 most influential people in public health and has published over 100 peer-reviewed articles, is a TED speaker and a TED Fellow, Rolex Laureate, World Economic Forum Young Global Leader, Ashoka Fellow, and UBS Global Visionary. In 2023, Andrew was awarded the Thalberg Leadership Prize and an OBE in UK King's Birthday Honours. We're very delighted that Andrew is here, and we'd like to welcome him to give his talk. And it's very special that he gives his talk only from his laptop.
Thank you, Professor Moin, for the warm welcome. Good to be with all of you. 12 years ago, I was working in a rural clinic in Kenya, and it was an outreach camp, and we were calling patients to come for surgery. These two ladies had both been blind from cataract for 10 years, but did not know that despite previously being best friends, they were sat next to each other. It was only when we called their names that they realized that they were next to someone who had been a close friend for many, many years. But as they lost their sight, they also lost the connection to their friends and their family. The lady on the far side had burns all up her arm from cooking on a stove in her home without having sight. And her grandson was no longer in school as he was acting as her eyes. I was seeing this time and time again, and all because of something that is so simple. She simply had a cataract that could have been removed 10 to 20 years earlier. The challenge when we work as a clinician is we see the eye and we see what's happening in our hospital. We're always busy, but we don't necessarily see who's not coming, who's not in the system, who's not coming to receive our care. These are the people we consider to be invisible. And so with an amazing team over 10 years, we have been building systems and technology that allows people to go and find these people in their community, screen them wherever they are, at their home, in their workplace, in their school, and connect them to the services that they need. All of the data can be tracked in real time so that those managing the program can observe the program and respond to the barriers that patients are facing. It hasn't been a short journey. It's taken 10 years to build the system to a point where 1 million people were reached, and we celebrated that milestone 3 years ago. Pakistan really was the leader in driving this change. But since then, things have begun to take off, with over 17 million people reached, 7.5 million of whom have been from Pakistan, where lady health visitors, lady health workers, community screeners are finding and connecting people to every tier of the health system, all the way up to the point where ophthalmologists are seeing and managing them. We are working with partners across the world to deliver programs, research and implementation, and currently we're supporting our partners to deliver 115 programs in 13 countries. Every program has a different flavor and solves different problems, and we see screeners finding people who would otherwise never have accessed care. The challenge with data can be too much data, too much information, so we really focus on what we call the metrics that matter, which means of the people who have an eye care problem, how many of them who are there are actually found through screening. And with these digital tools, we've been able to triple the proportion of people reached in the same period of time, because you don't need an eye care worker. Someone who has got basic training and is smartphone literate can identify them. But finding them isn't solving the problem until they've reached the care that they need. So we track, of the people referred to a health facility, how many turned up, but critically how many did not, that were expected. That allows us to track the proportion of people connected to care. And most of our programs at the baseline show that only 1 in 5 people, so 20% of people found with an eye care problem, ever actually make it to care. And these are often the most vulnerable people in society. We've, over time, identified common barriers, things like people not being able to afford or access transport. So when transport and the cost of treatment is covered, we typically see this number increase to around 50% of people accessing care. But then the rest requires lots of iterative improvements. So for example, one program early in our time in Kenya showed that when we looked at the not connected group, most of them were from a specific ethnicity. And it turned out that when they were being counseled for surgery, a word was being used in Swahili, which was supasuaji. And when I asked somebody, what does that word mean? Because I saw the patient's face change. They said it means operation or surgery. When I heard the word used in a different setting, and I asked someone what the word means, they said it means butchery. So in that local language, there was not a word for surgery. So these patients were hearing it's free, we'll provide transport, and then we will butcher your eye. So not surprisingly, they chose not to come. But just by changing that word to something that meant fix, we saw the numbers go from 50% attending to almost 80% attending. So technology on its own doesn't solve the problem. It's the combination of technology and compassion when put together that start to create major change. And our philosophy at Peak is that better never stops, because once you solve one problem, you have to solve the next, and again and again and again. Our vision for the future is that we go beyond just reaching more people, and we're able to use the data to say, well, how many people are impacted across a whole region? And so we've been able to triangulate the data from the program in Pakistan to say, in a region of 7.5 million people, the forecast of future eye care needs is growing as the population ages and grows. But when we overlay the current program data, we can see when 150,000 people are reached a month, and almost half are reaching care that works, we've started to reduce the number of people in the future who will have vision loss. But that's not enough. The question we now want to challenge is, can we go further? Can we go fast enough and deep enough with high enough quality that we actually eliminate unnecessary vision loss? Bearing in mind, for the majority of people, these are not complex eye conditions. This is untreated refractive error. This is untreated cataract. So this is solvable if we can generate the demand in the right way. This is also aligned to WHO's targets. And when we do this, we see not only great statistics, but we see lives changed. Like these 2 ladies who were blind for over 10 years. This was them the day after their surgery. So if this change is going to happen, we have to change people's hearts and minds. So I'm just going to share with you a short formula in terms of how that can be done. So I very intentionally shared a story with you in a way that can be remembered. And I started with those two ladies' story and I ended with their story. Because people will not remember statistics, but they'll remember people. So let me prove it to you. The reason we start with why, so here's a picture from me from a few years ago. Brains and minds are wired for other people. So from the day we are born, our visual system is designed to recognize the eyes and the mouth and to create visual patterns and see faces. So we are hardwired for people. And I'll prove it because if I take my eyes and my mouth and I turn them upside down, I look really strange. But if I take that same face with the upside down eyes and mouth and turn that upside down, your brain will suddenly see something that looks more normal. And that's because your brain and visual system are wired for people. It's why we see faces in things where there are no faces. So the point is, people back people and people trust people. So data isn't enough unless there is someone behind it, such as the two ladies I described there. So always start with, who are we solving this problem and why are we doing it? Then the question is, what are we going to do to solve the problem? There are lots of ways you can think about innovating or having an idea, but there is a key difference between what we would describe as being a really good manager and being a really good leader. And it's possible to be both, but a good manager helps people climb the ladder. A good leader makes sure the ladder's on the right wall. So the job of the leader is to see far into the distance and make sure that whoever's moving towards it can do so with efficiency and the right energy. I want to tell you a good story about the moon landing in 1969. So 7 years prior to that, in 1962, President JFK visited NASA for the first time. And his big dream had been to get everyone to fly to the moon. And everyone was saying, this is such a ridiculous idea, so much resources, it's not possible, and so on. But what he got was everybody talking about it. Everybody was looking at the moon, thinking one day we're going to land on the moon, this thing that was so far away, so seemingly impossible, like reversing the trend of vision loss. And he told everyone that's what we're going to do. And whilst he was at NASA, he was walking around and there was a janitor there who was cleaning the floors. And so he saw the janitor and he went over and spoke to him and he said, so tell me, what is it you do here at NASA? He said, I'm helping to put a man on the moon, sir. So he was clear that his role was contributing to the big goal. He understood that by cleaning the facilities, by looking after it, he was helping the team to eventually deliver that big goal. And so when we're describing the what we're going to do, we have to provide a clear vision for the future that people can see for themselves so that they can align their own roles, their own energy around that. Then there's how do we do it? How are we going to get there? And this is where all the challenge happens. This is all the unknowns, all the uncertainties, all the difficulties, all the problems that are inevitable on any pursuit. But I would say the biggest question to answer if you're leading people or an organization is not how will you do it, but who will do it. Because the answer always comes in having good people. Good people will work out how. The role of the leader is not to determine how, it's to determine what, and to find the right people who will work out how to do it. I'm very fortunate to be surrounded by brilliant people who everything that you see that I've presented has only been possible because of the work that they do. And if you like, this recipe for change isn't new. So many of you may be familiar with a very famous speech by Martin Luther King. In that speech, he shared his dream. He starts it all with, I have a dream. And it was in front of tens of thousands of people, and it started a huge movement, the big civil rights movement. But apparently, he had told that speech 18 to 20 times before, and it hadn't worked. Nothing had changed. To the point that his team were bored of him saying that speech. They're like, oh, Martin, you're not going to do the I have a dream speech again. In the same way, my team might say to me, "Oh, Andrew, you're not doing the two ladies talk again." But something happened on that day where he shared his dream, and it was the right people at the right time, and it began a movement. And notice he didn't start by saying, "I have a strategy," or "I have a plan." He started with a dream, and then that was translated into a strategy or a plan. So my encouragement to all of you is, if we dream big for what's possible in Pakistan, particularly for those who are not reaching eye care, for those who we don't see in our services, those who we're not innovating for, why don't we have a shared dream of how we reach them and bring them into eye care? So that ladies like this and many others who are living unnecessarily with vision loss have a new story. Thank you very much for listening, and if you'd like any more information, my team are here with me, Fahana and Bilal, and if you scan this QR code, there's some information on our website. Thank you very much.
Thank you so much, Andrew, for a very enlightening talk. And this is the way you change people and their hearts and move that motivation so that things can happen. Bringing a change is really a very difficult task. The next talk is going to be the Sayyid Ali Haider Memorial Lecture Award. Professor Sayyid Ali Haider remains General Secretary of Ophthalmic Society of Pakistan. He was one of the giants in vitreoretinal surgery, and he trained a lot of VR fellows at Lahore General Hospital. He was trained at Oxford, and in his VR fellowship there, unfortunately, he met with a very brutal murder, and that was sort of condemned by all the ophthalmic community and everybody in Pakistan, and was a huge loss for our community. And we remember him this day and pay a tribute to him, and sort of dedicated this lecture in his memory. And today the lecture is going to be given by Dr. Helena Pryor Philippi. She's going to talk on from vision correction to vision creation, leading ophthalmology's future. Professor Helena is a clinician, educator who integrates advanced ophthalmic practice with global leadership in health profession education, a graduate in medicine from the University of Lisbon, and trained in ophthalmology at Instituto Gama Pinto. She serves as consultant in the Department of Ocular Surface and Cornea at the Hospital de Egas Moniz, Western Lisbon Local Eye Unit, and an associate researcher at Egas Moniz Center for Interdisciplinary Research. Clinically, the expertise include ocular surface disease, cornea, cataract surgery, and ultrasound, with active participation in international consortia on ophthalmic drug delivery. Helena has recently been chairing the Department of Low Vision and Rehabilitation, equally dedicated to education. She earned a master's in innovation in continuing professional development, curriculum design, simulation-based education, and mentorship. She has chaired educational committees for several global professional organizations such as ICO, ARVO, and Ophthalmology Foundation, AMI, and European Board of Ophthalmology, among others. Recognized as a fellow of AMI, SAME, and the European Academy of Clinical Leadership, Helena continues to shape global faculty development and CPD with commitment to excellence and collaboration. Thank you very much, Helena, for joining us today.
Very good afternoon to everyone. It's an honor for me and a pleasure and a privilege to be here. And I could almost stop here because of the marvelous, inspiring lectures that we have been listening before. I start with my bowing and feeling humble before the inspiration that Professor Sayyid Ali Haider gives to this lecture. And these are some of the words of tribute to his presence. And I feel very humble to be here, and it's a distinguished privilege to be here. So I thank very much the Pakistan Society of Ophthalmology highest leaders for the invitation. So we are going to speak a little bit about leadership, or continuing to speak about leadership, because we have been hearing about leadership previously. leadership is something that can be defined in different ways, in diverse ways, can be looked with several perspectives, diverse perspectives. We all know that leadership is important, nevertheless, that clinical skill is different from leadership skill. And what exactly we have been listening before is something that embodies exactly this statement. So it's necessary for, and we are responsible, accountable to our patients, to the society, to behave and develop leadership skills. Leadership matters, especially in times as we are living right now. Probably we all live in changing times, but right now we can feel those shifting landscapes, emerging challenges, aging population, global equity gaps, climate impact on eye health, just to name a few. So great clinical outcomes are connected, are associated with clinical, but also with leadership competence. And we know that most physicians have not had formal leadership training or experience. So we should develop roles and competencies beyond medical expertise, and we can see those reflected on frameworks for competency-based medical education. So it's a must also for training present in the curriculum. We should develop an adaptive, inclusive, distributed, and compassionate leadership mindset for quality improvement and for patient safety, to have a holistic, whole perspective of what we do, of the services that we provide, the place that we occupy in society, being ophthalmologists within our profession, and also develop self-assessment and metacognition expertise, to build teams, to be able to build teams, to create teams able to learn, respond, and work together. So the purpose is to create this leadership culture, this feeling of responsibility, of occupying a place in a team, and being aware of the importance that our work contributes for the success of that team, exactly as we heard before. In ophthalmology, influencing several circles. We can start by micro level, we can be leaders at the micro level, our individual practice, at our practice setting, our hospital clinics, at the meso, so having some influence, some impact with what we do, and probably we will all as individuals, and working with teams at the hospital practice, and at the macro level, at the healthcare system, as we have heard so brilliantly and eloquently before. So are we born leaders, or leaders are already born and we don't have the access to be leaders? We can think about that and be very comfortably sitting on a sofa, but we can also take the other attitude and develop leadership skills within the team where we are, within the clinic, the organization where we work with. So leaders prepare organizations for change, and change can be very exciting for some and can be very frightful for others. But we know that when things are not going right, they should be changed to be better by motivating people and setting direction. Organizations offering leadership development programs prepare for superior organizational and operational performance, and this is evidence-based. So there are various definitions for leadership. This is one of them. I like most especially this part, that leadership is a process. It's not a title, it's not a position, it's not an accomplishment, it's a process. It's something that is ongoing. It's something that we can develop with others and for others as well, to facilitate individual and collective efforts. And this vision of working together, working with others and for others, is so compelling to accomplish shared objectives. So let's start by self-leadership. We are all leaders or should be leaders. And I like to compare with this example as surgeons. The surgeon is a leader who promotes teams interdependency at the OR, creates or should create an environment welcoming teams' knowledge and skills. Everyone is important for the session of surgery to work well for the best interest of patients, the hospital, the healthcare system, for ourselves as well to feel accomplished as professionals. And a surgeon also practices distributed leadership. We have to work together in an OR, but we have to also develop a self-leadership because this is the foundation for resilience, for emotional regulation, and also for role modeling excellence. Another perspective of leadership is inclusive leadership. Inclusive leadership for well-being and psychological safety that were so emerging themes during the COVID. It's so important that the staff, all the team, has this well-being protected because the outcomes will be better. The patient outcomes will be better afterwards as well. And all the team and all the organization will reflect that. Fostering a culture of honesty and openness, by setting clear norms, accommodate diverse views, being an active listener, surface psychological safety, a climate, an environment where everyone can be heard and everyone has an opinion to be shared. Role model equitable processes. And as an example, I would like to share with you this inspiring talk. I would say I have just heard today as well. I could have also heard the photographs of the sessions before. And this is an impressive talking about mountaineering. And we can see these examples of leadership everywhere. And we can import them as well to our profession to inspire others. And thus, I felt that way, of a team who worked all year long to bring together all that is necessary to go and have these expeditions as a team, working together and knowing that everyone in the team was essential for the outcome that the team had offset become possible. Distributed leadership is about sharing responsibilities. It's about collaboration and decentralizing decision-making. It's about trust. It's about role modeling as well. It's about engaging, empowering team members to engage, and we can leverage the expertise of different cadres of professions. This is quite important, for instance, in quality improvement collaboratives and integrated care, for instance, workflows, theater lists management, triage. This shows shared leadership improves sustainability systems. We can, example, for instance, by practicing or performing group mentoring, multiple mentors and mentees engaging in shared learning. So this is quite a laboratory of distributed leadership. And also by creating communities of practice. Usually these environments of group mentorship can flatten hierarchies and everyone is engaged, knowing their role in the big puzzle and how important it is to accomplish the outcomes that the team is about. It's a real community of practice. Adaptive leadership is essentially important when problems are not technical. For instance, implementing new practice guidelines, improving trainee feedback culture, or shifting patient communication norms. So it's important for ourselves to be able to mobilize teams, to handle difficult, complex challenges and thrive and have this feeling of if we take this together, if we know exactly what we are expected to do and what we should do for the team to thrive, it will thrive. And by thriving the team, the individuals also with a sense of belongingness and uniqueness also feeling accomplished and fulfilled. and hold the environment for this collective adaptation, a trustful and psychological safe environment. Embracing vulnerability and uncertainty, we all know that I usually say sometimes that I doubt of someone who seems to hold all the responses for everything. It's good to doubt and sometimes to share those doubts and show that we are thinking about those doubts to arrive at the best solution and count on the team for that as well. Compassionate leadership. Compassion is not empathy. It has to be combined with action to be compassion really at the workplace. And these are the 4 behaviors of compassionate leadership. And it has been shown that compassionate leadership is usually associated with best patient outcomes as well. And to end, systems thinking leadership. We know that ophthalmic outcomes, and we have heard that very, very eloquently and inspiringly in the previous presentation, previous lecture, are the product not of one skill, not of one person, but of healthcare systems. Patients' referral pathways, theater flow, supply chains, training, supervision, digital records, the culture, the hidden and the shown culture are very important aspects, factors, elements to define success in the healthcare system. So system thinking leader should understand complex independencies of what an idea can be when put in practice and what can happen with those interdependencies with systems that can be physical, financial, human, etc. Sees patterns and relationships and roots causes, doesn't blame anyone per se, but roots the cause in the big picture and optimizes patient care through this holistic view of patient interactions and workflow. This is a table that takes us to how systems thinking is so important in quality improvement, in patient safety, in teamwork, in resource management. Evidence shows that systems thinking improves the patient's outcomes, and also we can act at those 3 levels that I've heard previously. So at the micro, at the meso, and at the macro level. There are various ways of putting this in practice. For instance, thinking about teaching and making awareness of systems thinking, of the complexity that is going around to be as a team, as an organization, to arrive at the best patient outcomes, at the best solutions, and impact the healthcare of the whole community around, of the country, of the region, etc. Promote systems thinking, engage everyone in the team with a role, and in decision making, in quality improvement, education, mentoring, and building interprofessional teams. Flatten the professional cadres and be just focusing on the best interest of the patients. And here we are already merging with systems thinking, distributed leadership, compassionate and also adaptive leadership, when we also adapt compassionate team culture leadership for clinical excellence. So there are several ways. We just have to be aware and bring that to the table of work, our table. Having asked ChatGPT about what will be the leader of the future, in this case was specifically the leader of the future in health professions education, but we can bring this as well for the healthcare professional as well. And as you can see, it's not about traits only. It's not about characteristics, but it's also to have a vision, to communicate this vision, and also to have the others rowing the same direction. Not the same row, not doing the same thing at the same time, but being harmonically working together and develop those skills. The leader of the future continues to evolve to that place where people will follow by what he or she or the team has accomplished, not by imposition, adapts. The leadership can be adapted in the context of the team that is to work with. More confidence, more competence, so we can adapt, supporting, coaching, directing, etc., and inspires. And I'm finishing with this sentence about this definition of leadership that also is very compelled my interest very much, because leadership is viewed not only as a position, as a title, but as a privilege, as a responsibility, because leadership can influence and alter the life for very important ways with the ones that we work with. Thank you so much.
And we move forward, and now we have the Professor Muhammad Latif Chaudhry Lecture Award. Professor Latif Chaudhry is an icon in ophthalmology in Lahore and in Pakistan and in the Asia Pacific region as well. He has served as the Ophthalmic Society Lahore branch as president 2 times, 1979 to 80, 1988 to 1989. His president remained the president of OSP Center, remained the dean of ophthalmology at CPSB, and most importantly, he chaired the Department of Ophthalmology at Fatma Jinnah Medical College, and he transformed that college and the eye department at that place into a tremendous institution, a place where huge service delivery was done to the patient, cutting-edge vitreoretinal surgery. And I think he was one of the members who started this Lahore Ophthalmo and brought this name of Lahore Ophthalmo to the Ophthalmic Society of Pakistan Lahore branch. And he brought innovations, and he brought Robert McAmmer from all the way from the USA. He went there, and John McQueen was here, and then there was a transfer of technology in VR, and he was lucky enough that he did it all by himself. He established a clinical institute in the private department as well. All his children are ophthalmologists, and what a lucky day that his son is going to become the president of the Ophthalmic Society of Lahore branch in the next 2 days. And for this lecture, I'm going to introduce Professor Alvin Young. He's going to deliver the talk on surgical dilemmas in pterygium surgery. Professor Alvin is an honorary clinical professor of the Department of Ophthalmology and Visual Sciences at the Chinese University of Hong Kong, visiting professor of Shantou University, Joint Shantou International Center in the University of Hong Kong. He's currently the Deputy Hospital Chief Executive and Chief of Services at the Prince of Wales Hospital. He also was previously the Chairman of the Hong Kong Hospital Authority Coordinating Committee in Ophthalmology. Professor Young is a champion for cornea, dedicated to anterior segment advancement and education through the Asia Cornea Society, Asia Pacific Artificial Cornea Society, and the Hong Kong Society of Transplantation Council, and thesis member of the Corneal Society over the last 20 years. He takes an avid interest in mentoring aspiring younger generation. 80 fellows and residents were trained by him in China, Asia, Middle East, and South America. Professor Young is recognized as elite status in the midfield and serves as the section editor for APGO and I. He has ranked the world top 2% of scientists in ophthalmology and optometry, and with a respectable Google index of 51. He has served an external assessor and examiner for various Australia, New Zealand, Singapore universities, ophthalmology fellowships in Scotland, and the Macau Health Bureau.
Why am I here? This is my first time in Pakistan, and I'm extremely honored to be here, especially after the previous distinguished speakers who gave a global view on how we can help more people, and also in terms of developing future leaders. I was born and bred in Hong Kong, went to rather elite school until I was about, I think I was 14. Then I moved on to Dublin. I went to another elite school there, where I continued my medical studies in UCD, and then subsequently trained my ophthalmology in Malta under Professor Peter Eustace and Michael O'Keefe, etc. How did I end up knowing Moy? We were in Galway together for 6 months. We shared a house together. We worked in the same department, and we were trained by Mr. John Nolan, who sadly left us this year. He was actually an Oxford Congress of Ophthalmology Congress Master in 1995 to 1996, and he was a true gentleman. And subsequently, Moin and I passed our fellow Edinburgh exams together in 97, and then subsequently we stayed in touch and met at many, many meetings. And here I am today in Lahore, in Pakistan, for the first time. I'm very honored and humbled to be here among esteemed clinicians and scientists, and look forward to learning from you all. This is the outline of my talk. I don't think I would overrun. I can probably gain some time as I don't have to play all the videos. I know it's getting quite late. So you're all familiar with this rather common problem. I'm sure you see quite a lot in Pakistan too, because you get sun. So what are the geographical prevalence risk factors for pterygium? This is a fairly large systemic review and meta-analysis done about 10 years ago, looking at almost 1 million samples from 20 studies, giving a relative poor prevalence about 10.2% in our population. So who are at risk of developing a pterygium? If you're male, you get an odds ratio of 2.32, and it also increases with age, and it probably plateaus off when you hit 60, and then level off to 70, about 20%. Sun exposure gives you an increased risk, 1.76. So how common is pterygium? Pterygium is fairly common. We don't have actual figures per se, but according to US data, about 9.4 million patients globally are probably candidates for pterygium surgery. So you can imagine how common a problem this is. Despite various adjuvant therapies, there are still recurrences with each treatment modality, whether you use Bayes-Thera, conjunctival autograft, various adjuncts, or amniotic membrane, etc. So who are at risk of developing a recurrence? A recent review looking at recurrent pterygium risk found these factors. Obviously, duration of follow-up. The longer the duration, the higher chance you're going to get a recurrence over time. Some basic mechanisms increase, including increased MMP, P53, anti-VEGF, and a BRAF 600 mutation, and certain viruses are implicated as well. Demographic factors. If you are young, less than 45 years old, with an inflamed ocular surface, in recent years, dermatitis has been a popular pet study subject if you're African American. And then in terms of the surgery, certain experience is of importance. The size of the pterygium and effectiveness. And also the use of sutures may actually associate increased risk as well. So in terms of management strategies of a pterygium, you can start with these 5 factors: lifestyle, medical, surgical, intra-op, and post-op. So UV exposure, try to cut that or wear UV protection. Lid hygiene, reduce the inflammation in the eye. In terms of medical treatment, you can use MMC, I5FU, and steroids and anti-VEGF as adjuncts to your surgery. In terms of surgery, you can do conjunctival autograft, conjunctival graft, amniotic membrane, or even SLED as a newer procedure. Preoperatively and postoperatively, you can give injections, either injection on table or subconjunctival application pre-op, or as drops. More than a decade ago, a report by Stephen Cochran looking at the AAO report looking at pterygium surgery adjuncts, looking at primary and recurrent pterygium. In terms of recurrent pterygium studies, basically only 3 reported a significant difference. One of them was a conjunctival autograft, and the other 2 were mitomycin C. We look at our own results, and we published this long-term recurrent pterygium study, a 15-year follow-up on RCT cohort of 62 patients randomized into 3 groups. Limboconjunctival autograft, mitomycin C, and combined limboconjunctival autograft and mitomycin C. The mean time of operation study was 16 years old. There was only 1 recurrence in our study, giving overall recurrence of 2.5%, and it was in the limboconjunctival autograft group, with no recurrence in mitomycin C or the combined group. What about intra-op versus pre-op mitomycin C? In another randomized study with 50 recurrent pterygium, there was no differences between whether you give intra-op or pre-op subconjunctival injection. So therefore, it's actually more convenient giving it intraoperatively. In terms of anti-VEGF, the wonder drug, it did not actually reduce any recurrence after pterygium excision. Whether you're giving it as a drop or whether you give it as an injection. In terms of recent paper in 2025 looking at recurrent risks, 2 additional factors were noted. One is a higher pterygium grade that we already know from before, and the other one is an increased neutrophil lymphocyte ratio. But I think this is really for study purposes, and I probably don't think anybody would do this as a routine. Amniotic membrane, it can be used as an adjunct, but if you use it on its own, it's probably not very good. If you combine with mitomycin C, the outcome is actually as good as using it mitomycin C with conjunctival autolymphograft. So these are the considerations I would think about in recurrent pterygium surgery, which is the most difficult thing we have to handle in terms of pterygium surgery. You have to consider the extent of excision versus the conjunctival loss when you deal with the recurrence. You have to think about goblet cells replacement for the dry eye. You have to think about the treatment-related complications such as future surgery, graft complications, mitomycin C complications, or complication of treatment per se. If there's symblepharon and pre-op morbidity, you have to replace conjunctiva and probably symblepharolysis. And then cosmesis, either it can be very vascular from recurrence or avascular looking for mitomycin C. Why do we use mitomycin C? Well, this is basically the reason. Glaucomatous blindness has increased by more than 129% just in China alone over a 10-year period. And with aging population, it's probably going to increase with time. And you know, glaucoma is a never-ending disease, and even with surgery, labs can fail over time. So the more normal conjunctiva you have, probably the better it is. Versus against the potential complication of mitomycin C melt, that is often heightened by those who are against mitomycin C. In our long-term study and amongst all of the other publications that we have, and also our 20 plus years of experience, we have not encountered a single case of steroid thinning of melt from the use of mitomycin C according to our protocol. However, in terms of appearance, the mitomycin C was a bit more vascular comparing to not as nice looking as the conjunctival autograft. So its cosmesis is an issue. You should think about conjunctival grafts as well. So this is just a picture to show you the different appearance in terms of grade A, grade B, and grade C. How much time? 5 minutes, okay. These are just some videos of what I do in terms of everyday surgery. On the left-hand side is what I teach the newer trainees, something what I call fishing. To me, it's like, hand-shredded chicken. You actually peel off the pterygium and then you cut it off. Whereas the right-hand side is probably for my fellows. It's a subconjunctival dissection. It's more like Peking duck. You need to separate the pterygium from the conjunctiva from the underlying pterygium, hoping to preserve more conjunctiva. It's technically more demanding and you can easily control. I was in Washington World Corneal Congress at the beginning of this year, and my American friends don't really like mitomycin C. And all the previous papers I've published or previous talks I've given, I've always been asked, why do we use MMC? This is how we do it. We put MMC on a vitreous sponge. We are not allowed to cut into small pieces like our glaucoma surgeons do because of quality and safety issues. So we moisten the sponge and then we stick it underneath the dissected conjunctiva area, not on the denuded cornea, not on the bare sclera per se. And this is just a video to show another example. I'm not going to show this, we're short of time. So this is a post-op appearance of what a broad recurrent pterygium after MMC can look like. This is recently post-op. This is probably a few months post-op. And this is long-term post-op with no recurrence. So to finish it up, these are just a few videos to show you the pretty standard technique. Oops. I'm not very good at this. How can I play the videos? On top left is just a routine conjunctival autograft harvest, and then you fixate it with a needle with protein suture. On the left bottom side is about limboconjunctival autograft, where you harvest a little bit of the limbus as well. And then on the right-hand bottom side, you fixate it with blue blooded sutures. It's supposed to give you better results in terms of recurrence as well. Conjunctival rotational autograft I would consider in cases where there's not good conjunctiva. The slides are horrible. My slides are stuck. Okay. Conjunctival, this video is not playing. I checked it earlier on. All the benefits of use a conjunctival rotation autograft, you get all the benefits of a conjunctival graft with the tissue barrier reconstituted, with the low stimulus for reproliferation, and there's no conjunctival disturbance. However, this is technically even more demanding, as you need to preserve a diseased area and a very, very clean dissection. And then cosmesis is variable. You can sometimes get increased injection over time. But combined with mitomycin C, the results are fairly good. So the take-home message, prevention is better than cure. So get it right the first time when you do a primary iteration and try not to get a recurrence. Adequate excision of the subconjunctival fibroblastic tissue is the key. Intraoperative mitomycin C is an effective and safe treatment in our center with more than almost 30 years of experience. Conjunctival autograft gives you better cosmesis, but you need to weigh against the disruptions to the limbus and don't decide for future scarring and or glaucoma surgery. Fibrin glue has the benefit of less inflammation and earlier graft adherence and vascularization. I wish to thank the Ophthalmology Society of Pakistan for inviting me and my team back home for supporting me while I'm here. Last but not least, I would like to invite you all. I know APO is in Hong Kong, but the Asia Cornea Society Congress will be held in Hong Kong for the first time at the end of the year as well. So thank you for your kind attention.
Thank you very much, Alvin, for giving a very nice talk on tracheum surgery, and that's one of the key problems we face in Pakistan as well. I think getting Alvin to come to Pakistan was quite difficult. Every day I'd get a picture from him that this is a blast that has happened and why you're calling me to this country. I thank him for his courage to join us, and I thank all the international speakers for joining us over here. As you see, when you come to Lahore, it doesn't seem that anything special is happening. So the next lecture is by Professor Abdul Jaleel Daulah. He's the President of Ophthalmic Society of Pakistan, 1994-1995. He was the Chairman, Department of Ophthalmology, King Edward Medical University, at that time King Edward Medical College, Mayo Hospital, Lahore. And he was trained under J.D. Scott in UK, and he remained one of the best and iconic teachers in Pakistan. I think even if I meet any of his students here, at that time, they always tell me that he was one person, even if they didn't do ophthalmology, they'll always remember him as a great teacher, and he would come in his white dress. I've listened to his lectures in the Patiala Lecture Theatre, and it would be a place where you would go and listen every day. And I was there, posted in Bahawalpur as well, and there I used to know that he used to go from here on an airplane every week, but he would go 1 or 2 days, but he would take a lecture at 5 or 6 p.m. in the evening, and the hall would be full. So that is the amount of service he did and the amount of command he had on education. And on top of that, he was and he established the vitreoretinal department. He started laser therapy, argon laser treatment first time in Pakistan, and he's got many laureates to his credit. And his son is also working as an ophthalmologist and lead consultant at Manchester Royal Eye Infirmary. And the lecture today, Abdul Jaleel Daulah Award Lecture, is going to be given on Managing Angle Closure in the Surgical Era by Dr. Khalid Hassani. Khalid Hassani is a fellow trained glaucoma anterior segment specialist who specializes in glaucoma and cataract surgery. He completed his medical school training in 2000 from Michael Degroot School of Medicine, McMaster's University in Canada. After completing his ophthalmology residency at Queen's University, he went on to complete a subspecialty fellowship in glaucoma and anterior segment surgery at the University of Toronto. Dr. Dr. Hassani is currently Associate Professor of Surgery at McMaster University. He has received numerous teaching awards and is heavily involved in teaching fellows, residents, and medical students. Dr. Hassani is also co-director of the Glaucoma Fellowship at McMaster University, which trains international eye surgeons.
The introduction, and I'm really privileged to be here at this prestigious conference. My talk today is entitled Beyond Cataract, Managing Angle Closure in the Surgical Era. As we all know, angle closure glaucoma accounts for 1/3 of global glaucoma blindness, with most cases being chronic in nature. Traditional methods, although somewhat effective, a lot of times do not address the root cause of angle closure and are associated with increased risks of complications and problems. Newer surgical approaches are aimed at addressing these concerns by addressing the main cause, whether it be the lens, angle, or ciliary body, to try to improve and restore outflow. And by doing this, we are improving outcome and safety for the patients. So who is at risk? The elderly patient, females more than males, strong family history, certain ethnic backgrounds, like mine, have a higher risk of angle closure. And we all know the clinical characteristics, the classic look of those who are at high risk. You know, the ones who come in with Coke bottle glasses, high hyperopia, shallow anterior chamber, steep corneal curvature, thick lens, short axial length, and anterior position of the lens and ciliary body. The key to any good diagnosis is the assessment. So the gold standard is dark room indentation gonioscopy, or compression gonioscopy with assessment of Capet lens. In addition, useful adjunct like anterior segment OCT to help identify structures. And one must not forget the important role of ultrasound biomicroscopy for the diagnosis of plateau iris. So let's review. How do we practically stage angle closure glaucoma? Because a lot of times it can be quite confusing when the patient presents to you. So keep it simple. Primary angle closure, 3 stages. Stage 1, primary angle closure suspect, PACS. Stage 2, primary angle closure. Stage 3, primary angle closure glaucoma. So what are these 3 stages? PACS is when you just have 180 degrees of narrow angles or occludable angles. Primary angle closure is the same thing, plus elevated IOP or peripheral anterior synechia. Stage 3 is when you have primary angle closure glaucoma with everything present: narrow angles, elevated IOP, and optic nerve damage. So we all familiar with angle closure glaucoma, the classic exam question. Narrow angles, acute IOP rise, corneal edema, mid-dilated pupil, headache, nausea, and vomiting. The newer terminology is acute angle closure crisis, so just keep that in mind. So what are the mechanisms of angle closure glaucoma? Well, if you don't remember nothing from this talk, remember this: 3 major categories. Number 1, pupil block. 2, high lens rise. 3, plateau iris. How do we remember these things? How do we distinguish it? The clinical clue is look at the iris shape at the time of examination to get clues. So on the left-hand side, you see the classic pupil block. You have a relative seal between the iris and lens, and aqueous trapped behind the iris, and the iris is bowed forward. On the right, you have high lens rise, where the whole lens complex is anterior, and you have a very shallow AC, both central and peripherally, and the iris tends to follow the lens shape forward. And finally, plateau iris configuration, where you have anterior rotation of the ciliary body, where you have a very deep central AC, but the peripheral AC is shallow, is shallow. And you get this very finger-like projection to the iris, a very flat central iris. It's very classic, like a plateau, as the name implies. In real life, it's never that easy. Commonly, the presentation is mixed, but the number 1 culprit in most of these presentations is what? Lens rise. Remember, lens rise. So how do we practically manage these patients? Keep it simple. Treat the main cause. If the cause is pupil block, address it with PI. Lens rise, lens extraction. Plateau iris, pilocarpine plus or minus argon laser iridoplastity plus or minus endocycloplasty. In real life, it's not that easy to distinguish these patients because it can present as a mixed picture. So it ends up being a combination of treatments. So this flow chart nicely summarizes things in a perfect world. Pupillary block, medical treatment, LPI, filtration surgery. Plateau iris, medical treatment, LPI, laser iridoplasty, filtration. Lens-induced, lens extraction. Very simple, right? No. Because we don't live in a perfect world, and a lot of times it's hard to distinguish the cause. So clinical questions you ask yourself, is this acute versus chronic? Is this patient medically controlled or uncontrolled? Ask yourself 3 anatomical questions. Is there an established PI present? If there's no PI present, pupil block is a component. Is there a cataract present? If that's present, that needs to be dealt with. Is there PAS present? If that's present, that tells you this patient had this problem for a long time. So general treatment approach. Max out the IOP lowering. Dump all the drops in, get that pressure down. Establish a patent PI, break the pupillary block. Throw in an argon laser iridoplasty if there's a plateau iris component. Lensectomy to deal with the lens rise issues. And if the pressure's still high, angle-based procedures like GSL, ECPL, MIGS, and so forth. I will talk about that in the future. And traditional surgery we save for the end, like trabs and tubes. Why? Because they tend to have a higher risk of complications. So, what about the patients who present with narrow angles but have no symptoms? Do we treat them or don't treat them? The traditional protocol in the past was do PI in all these patients. But the recent ZAP trial challenged this notion and basically said that LPI may not be necessary and only do it in patients who are highly symptomatic, have high risk factors like elevated IOP and very narrow angles. You see the list, the list there. Whether you decide to treat or not to treat, we'll leave that up to you as a clinician. But if you do decide to treat, always make sure to re-gonio the patient after the PI. Because the PI a lot of times does not solve the problem. Up to 60% of eyes can still be occludable, mainly due to 2 things: plateau iris or high lens rise, or sometimes both. So if you do a PI and the anterior chamber significantly deepens, boom, pupil block most likely was the cause. So you can see here, grade 1 angle, pre-PI, post-PI, significant deepening. But if you do a PI and there's no change in depth, still very shallow, one should consider plateau iris as a possibility, or very commonly, high lens rise, where you have a big fat lens taking up all the space. So the definitive treatment for these cases is lensectomy. And lens rise is usually a significant component in most angle closure glaucoma cases. So by removing the lens, you're removing the cause, you relieve the pupillary block, increase the anterior chamber space, release some of the PAS. What I tell patients is we are taking the fat guy out of the small room to create space. Many studies have shown that by taking the lens out, this helps with angle closure. And the most recent trial, the EAGLE trial, was a large randomized controlled trial from China, which looked at patients with primary angle closure and elevated IOP, and randomized them to clear lens extraction versus peripheral iridotomy. What it showed that clear lens extraction had better health outcomes, lower intraocular pressure, and was actually more cost effective. Now, when we're doing cataract surgery in these very small eyes, remember 2 major concepts. Number 1, space creation. Number 2, space maintenance, okay? So what is space creation? Space creation, remember the shallow anterior chamber, we're trying to create space to deepen the anterior chamber to help us take that cataract out, and we also want to protect the corneal endothelium. So this can be done preoperatively with IV mannitol. We're dehydrating that vitreous, making the vitreous softer, deepening the anterior chamber. You can also do it intraoperatively with super viscous cohesive OVDs, or mechanically with a pars plana tap to debulk the posterior segment. The concept of space maintenance is we're trying to maintain the anterior chamber during phaco emulsification in these very challenging cases to prevent intraoperative aqueous misdirection. We don't want that fluid traveling back behind the lens capsule. It's been quite a nightmare, causing malignant glaucoma. So how do we prevent that? Smaller incisions, less AC turbulence, and also maintain the anterior chamber at all times during surgery, either with an AC maintainer or with judicious use of viscoelastics. Remember, a lot of times when intraoperative aqueous misdirection happens, it usually occurs during cortical removal or when the lens is being placed in the eye. A lot of times AC shallows during surgery, fluid reroutes posterior, and you're in trouble. So I always tell my fellows and residents that before you come out with the IA, inject the bag with OVD. Keep that AC pressurized. Do not let it shallow. Once that's done, you can come out now. We're trying to prevent this problem, malignant glaucoma. Fluid gets back behind the lens and pushes the whole lens bag complex forward. causing aqueous misdirection, aka malignant glaucoma. How do we deal with malignant glaucoma? The definitive therapy is to create a unicameral eye. Basically, we just want one big channel between the anterior and posterior segment to allow the pressure to equalize between the anterior and posterior segment. And this is done with an iridozonular hyaloidotomy, or IHZV for short. IHZV comes in two approaches, the anterior approach and posterior approach. Anterior approach, you can do it in clinic. If you notice intraoperative aqueous misdirection in clinic postoperatively, you can use a laser YAG approach. Or intraoperatively, if it happens during surgery, for example, you can use a vitrectomy cutter through the corneal liver incision, or a posterior approach with a vitrectomy cutter through the pars plana. So here's a video of one of my fellows doing surgery, cataract extraction, everything's going hunky-dory, put the lens in, boom, we start noticing there's aqueous misdirection. So we're doing a conjunctival cut down, MVR blade 3.5 millimeters posterior, and trying to maintain the anterior chamber space with viscoelastics, and doing a vitrectomy cutter to decompress that posterior segment. And now we're going to do an IHZV, create that unicameral eye, create that big hole so that fluid can bounce between the front and back of the eye. And by doing this, you will see that the eye softens quite significantly, and then we just close up with atovicryl. Now, the most extreme cases of small eyes is nanophthalmos. A lot of surgeons will shy away from nanophthalmos just because it's really difficult. But if you do we decide to take the challenge on, we know that angle closure glaucoma can be effectively treated by lensectomy in these cases. But you have to be aware of two problems: uvular effusion syndrome and malignant glaucoma. So the concepts of space creation and space maintenance is very critical here. I would try to avoid pars plana taps in this case because the anatomy is very different in an ophthalmic eye. If you go 3.5 millimeters posterior to limbus in an ophthalmic eye, you're into the retina. So if you're going to do that, you have to go more anterior to that. With axial length less than 20 millimeters, or if there's malignant glaucoma in the fellow eye, approach it anteriorly with an IHZV approach. If the eye is really short, uvular effusion might be a high risk here, so you might want to do prophylactic sclerostomies, as seen here. You can either use a scleral blade, metal blade, or a diamond knife, as here. You're doing a scleral cut down right to the suprachoroidal space to allow fluid to egress. Sometimes here you can have uvular effusion already, and fluid is coming out, as you can see here. Now, what if we take the cataract out? Everything's good, but the pressure's still high. Then you have to ask yourself, is the angle open or is it closed? If the angle's open and the pressure's still high, your trabecular meshwork is done, is damaged permanently. So if the angle is closed, it could be either malignant glaucoma, which we just showed, or it could be peripheral anterior synechia or plateau iris. So let's talk a little bit more peripheral anterior synechia. So with using intraoperative gonioscopy, you can see in the top left-hand corner the classic look of PAS. And you can see on the anterior segment OCT the classic pulling up or intensing up of the iris, classic, which you see in peripheral anterior synechia. The management of PAS, the more you can release that PAS, the greater the likelihood of success. If you're doing phaco alone and it's just mild case of PAS, sometimes the phaco alone can relieve the PAS. However, if you have a lot of PAS, more than 4 clock hours, then GSL, aka goniosynechial lysis, is very helpful here. It's best performed with phaco emulsification, and 90% success rate if done within 6 to 12 months. Most patients get off meds. So let's look here. Another one of my fellows doing goniosynechial lysis using intraoperative mirror. You can see she's taking the micro-grasping forceps, pulling tangentially to the center and slightly down. Boom, open it, look at that. Opening it up. All the trabecular meshwork is visible. Now it allows for more flow to go through the trabecular meshwork. The other case where you have persistent angle closure and high IOP is plateau iris. You can see how the iris plateaus. The lens has been removed, but you can see the peripheral narrowing of the angle still. So in these cases, despite doing lensectomy, you might want to do adjunctive procedures, either through an anterior approach where you're shaping the peripheral iris anteriorly with an argon laser iridoplasty. Beware of PAS formation there. That's usually done in the clinic. Or you can do it intraoperatively through a posterior segment, like posterior approach. And what is ECPL? That's reshaping the iris from behind. It's called endocycloplasty. It's a modification of the ECP technique. And what we're basically doing is taking the ECP laser and frying the posterior tail of the ciliary process. What it does is it causes shrinkage of the ciliary process and it causes the peripheral iris, which is really shallow, to open up. Okay, so what we're doing here is we're trying to reshape that peripheral iris in the plateau cases. Okay, so we've talked about narrow angles. We talked about patients who have narrow angles and the pressure still high. Secondary trabecular ventricular dysfunction is the final scenario where you have open angles, but the pressure is still high. Usually the natural drainage is totally damaged. So what do we do in these cases? We either do mixed procedures to reconfigure the natural drainage with either goniotomy techniques or stenting techniques. You could do MIBS procedures, which create a totally new drain with a mini bleb, either Zen or PreserFlow, or you could do phacotrab or tube, which has a higher sec profile. Most of the time, the cases are, you combine a lot of these techniques. So here's a case with a patient with severe PAS, and we're doing the goniosynovial. We're pulling that scar tissue, opening it up, okay? So once we open it up, we're like, now let's put some stents in. Boom, one stent is placed. Now we're creating a new artificial flow. That's one stent, iStent placed. A few clock hours to the right, we put another stent through the trabecular meshwork. Okay? So you think we're done yet? No, we're not. So what we're going to do now is we're going to open up the natural drain by doing a goniotomy. Now we use the tip of the iStent inserter, but one can also use MVR blade, one can use a 27 gauge needle, one can use a KDB, a hook dual blade. Doesn't really matter. What we're doing is we're opening up the natural drain. So you can see we're combining different techniques to try to restore the outflow. We took the lens out, we opened the scar tissue, put some new drains in, open up the natural drain. So this is how angle closure is dealt with in the new modern surgical era. So I sincerely hope that you found this talk practical and useful and was a good overview to the management of angle closure. Remember, optimize medical treatment, establish a pain PI, remove that block, lensectomy for the lens rise, address angle anatomy as needed for plateau or PAS, and restore outflow with a myriad of different types of surgical techniques. Thank you very much. And most importantly, Pakistan's in the body.
Thank you, Khalid, for a very nice talk on glaucoma. I think it's one of major issues in Pakistan as well. And the next and the last lecture is going to be the Professor Wasif Mohyuddin Qadri Memorial Lecture. He was a great gentleman, and he served as the president of the Ophthalmic Society of Pakistan from 1986 to 1987. He served as a professor of ophthalmology. He was a great educator. He served as the departmental chair at Allama Iqbal Medical College, which was later converted into Sims Institute of Medical Sciences. And he's a great contribution. He's got a huge number of trainees who are here and abroad, and they bring laureate to his name, and he's remembered very highly in the ophthalmic community. And the talk today is going to be given by Dr. Yasir Khan on modern blepharoplasty, personalized techniques for functional and aesthetic success. Dr. Yasir is the medical director of Carrot Eye Center Clinic. He's a fellowship trained in ophthalmic plastic and reconstructive surgery. He completed his med school from McMaster's in Hamilton, Canada. He went to complete his residency at the University of Toronto, which he completed a fellowship in plastics at the internationally renowned Oncology and Oculoplastic Service at the University of Cincinnati, Ohio. He's clinical assistant professor of surgery at McMaster University and the director of medical school undergraduate ophthalmology program and the oculoplastic program. He is also a lecturer at the University of Toronto Department of Ophthalmology in his academic capacity. Dr. Khan is one of the only few trained and specialized surgeons who specialize in cosmetic eyelid surgery and reconstructive surgery of the lid, mid-face, and surrounding structures such as the eye socket and tear duct. Having performed nearly over 1,000 eyelid, tear duct, and orbital procedures, and being also an ophthalmologist, Dr. Khan is a true expert with the people consider any kind of eyelid surgery. His experience allows him to truly nurture the eyes while rejuvenating the eyelids and face. Dr. Khan is the founder and CEO of the non-profit Give Global Initiative for Vision Eye Care. He believes in giving back to greater good for striving to preserve and restore eyesight to the medically underdeserved population around the world. Dr. Khan brings to his patients care, experience, compassion, energy, innovation. He's constantly known for bringing only the more innovative and latest techniques in managing cosmetic and reconstructive surgery. Dr. Yasir Khan.
Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you so much for inviting me, Moin, and the rest of the team here. And so far, an excellent conference. I don't know where Moin got that bio from, but it's a longer version, definitely. I sent him a much shorter version. I'm going to be talking about actually the lower eyelid blepharoplasty, which is the more challenging one to do for 2025. Now, I consider myself, as an oculoplastic surgeon, a mid-face expert, and there's no one better in the world than me and us, meaning oculoplastic surgeons, to do the eyelids. We truly are the eyelid experts. We try and hide our feelings, but we forget that our eyes speak. And it's all about the eyes, right? I tell my patients that when we look in the mirror, the first thing we see is our eyes, right? The first thing we look at is our eyes. When we look at somebody else, the first thing we see is their eyes, right? So it's all about the eyes, and if the eyelids are rejuvenated, that frames the rest of the face. So that softens the rest of the face. So even if you have facial descent or your nose is maybe not ideal or whatever, it doesn't matter, because all that facial descent and aging is given a positive, softer look if your eyes are rejuvenated. So it's all about the eyelids. Thank you. Just for patient confidentiality, please don't take any pictures of my patients, and the slides are not for copy or distribution. So what do we consider young and attractive? Okay, so there's a few things that have been defined over time of what's considered young and attractive. One is the smooth eyelid cheek transition. So transition is very important. A long horizontal fissure, lateral angle, and the almond shape of the eye, and basically sort of tight skin. And I mean, this is not a trend. This is very common, and it's all about people feeling confident. This is Elizabeth Hurley, who's a well-known actress at 39, and this is her at 56, right? So you can see a few changes, but her eyelids have, I mean, she's clearly had some work done, because her eyelids have remained quite consistent, which is not by accident. So if you look at aging, the lower eyelid is very, very key when it comes to aging. And what happens when we age is, the first thing is volumes. We basically lose our infraorbital and orbital malar grooves, and there's orbital fat that prolapses. We also look at other signs of aging is the lower lid laxicity. So as we age, we get increased scleral show, the horizontal shortening of the fissure and rounding of the lateral corner all occur as we age. And you can see here, there's no pointer, is there? Any pointer? And then finally, we get laxity of the eyelid skin. So we have collagen that keeps the skin tight. So it's not like we grow more skin as we age, as time goes on. We lose that collagen that supports the skin. So people always say extra skin. It's actually not excess skin. It's actually loose skin, because we've lost the collagen, thank you, that supports our skin. And also, you can see here what we lose a lot as well is fat. We lose fat as I said, in the infraorbital area and also the orbital malar grooves. So this is basically, again, the ideal, the vision of a young eyelid that has been shown in paintings throughout time. Again, the smooth eyelid cheek transition, the short eyelid vertically, the long horizontal fissure. And this is actually consistent amongst many cultures, as I'll show you. And facial beauty is really linked to the eyelid fissure. And studies have shown and have demonstrated that the narrower or the narrower vertically the eyelid fissure, the more attractive someone is perceived. And like I said, this is really present across all cultures, from Asian to Black to South Asian to Caucasian, that almond-shaped, that sort of long horizontal fissure, acute lateral angle, almond-shaped of the eyelids. That's all consistent across cultures. So what have we learned from history when it comes to eyelid rejuvenation? So it's really mistakes of the past. Basically, it's taking too much skin off and taking too much fat off. Basically, it's doing transconj lipectomy with periorbital skeletonization, meaning taking too much fat off. It's taking too much transcutaneous skin and muscle excision with a higher risk of an eyelid malposition like a cicatricial ectropy and things like that. But mind you, I will say one thing that I've really changed over the last 23 years of doing this is that I think hollowness is overrated. A lot of patients actually don't complain about the hollowness. They complain about the ectropy and about the lack of skin remaining, about the fat that's still remaining after surgery. They don't complain as much about hollowness. So I think that the old thing about not to take too much fat off, it's a balance. And that's what I'm trying to get from this talk, is it's all about balance. This is a case that just did not go well. Kenny Rogers is a very well-known American actor, and this is what happened. So this is not Kenny, Kenny Rogers, sorry. And you can see he obviously had a blepharoplasty that just was not ideal for him. So what is the basis for lower lid bags, or what we consider lower lid bags? The cheek descent and hollow tear troughs are very important, right? And 52% of patients have this. The prolapse of the orbital fat, skin laxicity and sun damage, eyelid fluid, and also cheek festoons, where you get that sort of fluid gathering right at the nasojugal fold area. So the goal of today's lower lid rejuvenation or blepharoplasty is restoration. So it's all about restoration. It's about keeping things common sense. It's about restoring confidence. It's not about vanity per se. It's about restoring confidence to the patient. It's about paying attention to the lower complex of the periocular aesthetic unit formed by the eyelid, cheek, and lateral canthus. So eyelid, cheek, and lateral canthus. Those are 3 units. And it's like and they act like a single unit. And you can see here the patient, by simply addressing those 3, and simply, if you keep it simple, not making it complicated, by simply addressing those 3 things that I mentioned, you can really cause a really nice rejuvenation and give the patient her confidence back. So there's 2 different eyelid options, and I must admit, over 23 years, my perspective on this has changed a lot. There's a transconjunctival approach coming from inside out, and then there's the outside in, the transcutaneous approach. And I must admit, over the years, I've largely leaned back towards transcutaneous approaches, because I really think in order to address all forces affecting the aging eyelid, you have to really have a transcutaneous approach. I reserve the transconj for the really young patient who has no excess skin, who has no lid laxicity, which is actually, to be honest, in my experience, a small minority. And basically, almost any blepharoplasty can be done transcutaneously, whereas transconjunctivally, that's not the case. My surgical strategy is varied. Now, there's just general principles, right? Not everything applies to every patient. You have to tailor it for your patient and make it specific. And there are different ways of doing this. But in general, my surgical strategy is to do a structural lift where you lift the eyelid by paying attention to the orbicularis and mid-face support. Then you also do the central support hollowness, which means fat resection or fat repositioning or redraping. And then there's smoothing of the transition zone, which involves skin and septal management and canthal realignment. But again, you always tailor it for the patient. But I do feel, again, the transcutaneous approach often offers the best overall holistic result for the patient. So what's the process? I do on almost every patient, but not every patient, because you have to tailor it, I do a transcutaneous skin pinch or skin excision. I do transcutaneous or sometimes transconj fat excision or repositioning, and I do an orbicularis muscle suspension. Okay, by this way, you tackle the horizontal lid laxicity, you tackle the negative orbital vector, and you also tackle the lower lid retraction. This is a young 34-year-old man who came to me for lower lid blepharoplasty. You can see he has all those elements of descent, of lower lid laxicity, of the transition zone being very obvious, and you want to smooth that transition zone between the eyelid and the cheek. And basically, when patients come in, I do a test in the clinic and I show them on the mirror. I say, listen, if I do this, compare your right eyelid to your left and see by just me doing this what a difference surgery can make, right? And I've smoothened out that transition zone that I talked about. The only way you can do that is externally. And basically, this is I kind of do that act to the patient, and the patient looks at it and realizes that just by smoothing of that transition zone, it makes a big difference, right? And so this is how I do my my transcutaneous blepharoplasty. This is him 1 week post-op, where intraoperatively I do my orbicularis, draping, and suspension, and I do suspend it sometimes at the superior orbital rim, but also sometimes just at the lateral orbital rim. And this is him about 3 months post-op. I didn't see him, he was out of town, but he sent me a picture of himself while he was driving, and he was very happy. And it's a natural result, nothing aggressive, nothing too radical. This is a patient that came to me with very similar facial descent. She was bothered by her transition zone, and she wanted this fixed. And so this is her post-operatively. I wasn't happy with this result. The reason I show this is that what's also important is the patient. What matters is what the patient thinks and not what the doctor thinks. I wasn't happy with this, but she was ecstatic and very happy. For her, whatever I did to her worked, and she was happy. So, you know, you leave them alone, right? So that's a different. So again, it's tailoring it to the patient and basically doing what the patient wants and giving them their confidence back, right? And it's not about my happiness, it's about the patient's happiness. And you can see that with the amount of skin, it depends on a lot of things when looking at skin excision. Okay, and what I typically do now is basically I mostly take skin out laterally, so I can suspend the orbicularis superiorly. So these days, for a lot of my patients, I'll suspend my orbicularis through the upper eyelid incision at the superior orbital rim at the periosteum. So you can see here, I've done my fat excision or repositioning. I've done a bit of my skin excision. I'll take the orbicularis muscle here with either a fibromerceline or fibroproline suture, and I'll suspend it through the upper eyelid at the superior orbital rim. And that pulls everything up, and it makes the transition zone I'm talking about smooth. And it's a pretty straightforward, simple procedure to do. You always overcorrect them because everything comes down. Gravity is kind to nobody. And you can see as I'm pulling the eyelid, that transition zone right there is smoothening, is getting more smooth, and it's decreasing and diminishing. So you can see here, I'll just fast forward it in the interest of time. You can see how it's suspended now. Okay. So this is another view. This is actually the Asian patient that I was whose picture I showed you before, and you can see how I'm suspending it at the superior superior temporal orbital rim at the periosteum. You can also do ligament release and fat repositioning transconjunctivally. I've got videos, but I think in the interest of time, we'll just skip the videos. But that's again transconj. But again, to show you some examples of the simple approach of lateral canthal ligament and orbicularis tightening and draping, skin excision, and fat repositioning or fat excision, you can cause a really nice natural result and restore confidence to the patient. Here's another example of a 60-year-old woman, again taking some fat out and doing the lateral tightening and the orbicularis muscle suspension. Another example of a patient 1 week post-op, pre-op, post-op. She had these dark circles, which you can't really remove, but you can actually minimize the dark circles through an optical illusion. By smoothing the transition zone, you can minimize the dark circles. You can't remove them, and you have to tell the patients, I'm not going to take them out, but I'll make them look better. And you can see that she was a very happy patient afterwards. The dark circles are still there, but that transition zone is diminished, and she's happy. She's about 55 years old. Another example of festoons and really kind of pulling the midface and doing a midface lift. This is another patient who's about 75 years old and was just unhappy with this, and you can see he had a four-lid blepharoplasty, I believe, and just redraping and smoothing that transition zone did that for him. Here's a young patient. A lot of patients would do transconj blepharoplasty on her. I chose to do an external as transcutaneous approach with a very small incision in the lateral canthus, and she was bothered by the dark circles and this transition zone. And post-operatively, she got this result, which she was actually very happy with. Dark circles are still there, but at least that transition zone is gone. She doesn't have that tired appearance, and she feels more confident. So in a nutshell, and I'll finish off with this, I do a temporal skin pinch and superior suspension in most of my blepharoplasty patients. Not everybody, because you have to customize it. I fix the hollow by either repositioning the fat, removing the fat, or doing fat sculpting by cauterizing the fat. And also, I try and preserve fat if I can. I don't excise a lot of fat. I'm very conservative with fat excision. But of course, you also correct the negative vector. You do the ectropiny repair. You fix the eyelid retraction, scleral, anything anything that's going on, the entropion and things like that. So in conclusion, I think the take-home message I want to leave here is that keep it simple and common sense. It's all about restoring confidence to the patient. No one option fits every patient. There's different ways of doing things, whatever works for you and works for your patients, and keep it simple. Thank you.
Thank you very much, Dr. Khan. With that, we come to the end of the session, and now I'll request the speakers to collect their shield from our come in front of the stage, and I will request Professor Latif Chaudhry first to give prize to give his shield to Professor Mia Muhammad Shafiq first. Shield.
I'll call each one by one. So first we'll give Professor the Ramzan Ali Sayyid Award lecture. Sir. Next, I'll request Professor Andrew Bastoras to come in and receive his shield. And I'll request Professor Salim Akhtar, sir, Professor Salim Akhtar to come and give the shield. Thank you. And next, I'd like to request Professor General Mazhar Saq to come and give the shield to Dr. Helena Philippe. Next, I'd like to request Professor Alvin Young to receive his shield from Professor Latif Chaudhry, delivered the Latif Chaudhry Award lecture. Thank you. Next, I'd like to request Professor Abdul Jalid Daula, sir, to give the award to Dr. Khalid Hassani. Glaucoma, I think one of the favorite topics of glaucoma after retina. Professor Jalil's most favorite topic after retina was glaucoma. And in the end, I'd like to request Professor Asad Aslam Khan to come over here and give the lecture, the shield and the award to Dr. Yasir Khan. the end. I'd like to thank each and every one of you for staying with us for such a long time. And it's been a long day. And after this, we are going to the inauguration. That's going to be about another half an hour's time. That is going to be in the Crystal Hall. There'll be inauguration. The foreign speakers will all get their gifts and souvenirs at there. So they'll be called and they'll have another photo shoot over Grand Ballroom. Crystal, we are sitting here. Will be there, and then they have national awards for the sort of people from all across Pakistan, and then there'll be dinner over there. The place where we had the presidential dinner last night, the Grand Ballroom. Thank you.